All right, good morning, everybody. Thank you so much, Maron, for the opportunity to get up an hour earlier than I usually would on a Sunday. So you've all made it for the time change, and I wanted to share a case from the past month or so. This was a gentleman who came in early morning, I think on a Tuesday. He was 37, had diabetes, but wasn't that compliant with his medicines. And he came in and said, hey, you know what, my blood sugar's high, I have pain in my legs, and I'm thirsty. You can see his initial vitals in the emergency room. He was a little hypothermic, tachycardic, normotensive, and not hypoxic on room air. Very overloaded on exam, had really anasarca to his legs. Indeed, his finger stick was high, and you can see the cardiomegaly and fluid overload on chest x-ray. So they sent him off and waited for the standard labs to come back, and over the next hour or two, you can see some of these results. Really multi-system injury on his labs, liver enzymes severely elevated. He has a thrombocytopenia, coagulopathy, kidney injury, and fairly severe electrolyte derangements. Because of the liver injury, they started off with some imaging of the abdomen. Along the way, caught a little bit of the lower part of the thorax. You can see the pleural effusions that he has. Interestingly enough, on the abdominal ultrasound, his liver had normal texture, no ductal dilatation, but a fair amount of ascites. And you can see his sinus tachycardia and IVCD on the electrocardiogram. And so because of this liver injury, and the electrolyte derangement, was given a hyperkalemia cocktail, and hepatology recommended acetylcysteine and admission to the MICU. But because of some of the cardiomegaly and fluid overload, someone sent off other testing, which then came back in the early part of the afternoon. And you can see the lactate and BNP values there. And so because of this, before they gave him the MICU bed, they called the cardiology fellow. Now, I was off in clinic, but he sent me these pictures on my phone when he came by to evaluate the patient, did a quick bedside echo. You can see a very severely enlarged and hypokinetic left ventricle. The reason for that white glare is he's standing there in the ER taking pictures of this and sending it to me as I'm over across the street seeing patients in clinic. So we referred him for emergent catheterization. He had normal coronary arteries, but was in fairly profound cardiogenic shock, wedge pressure in the low 30s, PA sat in the low 50s, and an index of 1.3. We put in a PA catheter and, in his case, an Impella support device, also with an antegrade sheath for leg perfusion. And we sent him to the CCU. And here the story began to unfold in a little bit more detail. What we originally had thought was an encephalopathy in the emergency room, probably multifactorial from his liver injury, from his kidney injury, maybe also from cerebral hypoperfusion. Turns out that underneath it all, he was schizophrenic. As we contacted the few family members who were still involved, was often homeless, really didn't have access to medical care. It was a little bit unclear, frankly, if he'd had heart failure before. When we mentioned that word, they said, oh, yeah, maybe he had that, and maybe his dad had it too. The patient then, in retrospect, perhaps of his December, which was about 2 months before admission, had begun to complain of dyspnea and cough. You can see the formal echo here in the CCU. Actually, some microcavitations on the M mode there, in addition to really severely reduced LV performance, a dilated ventricle well over 6 centimeters with very minimal contractile function while he was on that mechanical support device. And it was a very slow wean then over the next several weeks. He stayed on the Impella for about a week or so, and then balloon pumped for another 2 weeks with varying pressors, as you can see there listed, and then came off of them for about 2 weeks before he had to go back on. This is another repeat M mode and echo when he was off all support. Again, it's the reason I had to label systole and diastole here is it's perhaps not so obvious which one is which. He has really almost no cardiac performance. This is a graph showing the time course of his multi-organ failure. In the upper left, his liver enzymes, and then his bilirubins, lactate, sodium level, and white cell count. And I've annotated on there when he was on various levels of mechanical support. The liver injury that was really the most dramatic thing that the ER noticed and kind of went down that pathway first resolved fairly quickly within the first several days. Had a lot of hemolysis from the Impella, and so the bilirubin stayed high until we switched over for a balloon pump. His lactate levels came down fairly quickly, but then rose again when he came off mechanical support. The sodium levels came up, mainly due to CRRT, and he really always had an elevated white cell count, although we never found any evidence of infection despite quite a lot of searching. As you might imagine, for someone who was in the hospital for well over a month, he had all the usual ups and downs, and I won't read through every line on here, but you can see that it's the kind of prolonged hospitalization with multi-organ drama, if I could say it that way. The major challenge, of course, was his schizophrenia and the lack of family support. He did have one daughter who, frankly, rarely visited, unfortunately, and neither the patient nor the daughter had any deep insight. The patient himself had no capacity to make medical decisions, and actually late on Friday night, just 2 days ago, went into asystole and was not able to be resuscitated. Now, one of the things I wanted to emphasize about this case is that most shock is hypotensive. These are the 5 stages of shock. Stage C, classic from the recent SKY document that came out, and you'll notice their statement that most of these patients typically present with hypotension and indeed a low systolic blood pressure, or MAP, is one of the hemodynamic components to this definition. But our patient had pressures well above 90 millimeters of mercury systolic for the first day and a half, really. You can see the period I've highlighted in blue there when he was in the emergency department, pressures consistently in the 110s. And even after we put the Impella in, was able to use milrinone because he had a fair amount of residual blood pressure. And it took really 36 hours for him to transition into what I would say was more overt shock with lower blood pressures. Cryptic shock, or what we call normotensive shock, is just as bad as overt shock. This is some data granted from the septic shock literature, where overt shock is 5 times more common. Of course, the main differentiating feature is the systolic blood pressures, but you can also see that the cryptic shock patients have a much higher heart rate and average lactate levels, although the same poor hospital outcome. And so I'll, of course, refer to the panel for a discussion here in a moment, but these are some of the items that I know challenged us as the clinicians taking care of him. I think there was a fair delay in care in the emergency room because he presented with cryptic instead of overt shock, although I'm not sure it would have, frankly, changed his long-term prognosis. And then, of course, a lot of the challenges in mechanical support devices and how to deal with really an end-stage ischemic, a non-ischemic cardiomyopathy. Thank you so much.
Well, you certainly were in a dogfight. Dr. Paderoya, can you get us started here?
Well, I think he opens the discussion for something that we haven't discussed alone during this symposium too much is what we do when we save the patient and the patient doesn't have the resources to go to the next step. Because I think all of us have faced that. The patient comes, we acutely try to put the patient on temporary mechanical support, try to make him better, and then we face the fact that we don't have anywhere to go for those reasons, you know. So I want to ask, I think that's something that we need to work more and to work on what is the next step. And it's something that is hard when we have an acute patient that we don't have family or anything to find those questions. You know, we get a heart failure consulted and we don't know half of the patients. So I think all of us have said that, and I don't know if the other institutions have a plan for those patients when they come or not.
So, Steve, you know, we've heard about this being cryptic. How often is cardiogenic shock and acute MI, quote-unquote, cryptic? Because some of the data shows that patients don't slide into shock until 3 days out, and they seem to be, quote-unquote, non-shock-like early on. Could you comment on that? Is Steve not there? Oh,
no, he is down at the bottom.
Okay.
Way down at the end here, thank you.
Yeah.
So, well, I think it clearly is a continuity, isn't it? So that we see the results of inflammation, we see the results of myocardial stiffening and other things that are not the primary myocardial injury, but rather the result either of revascularization, microvascular changes, et cetera. So, you know, in this case, it certainly could have had a component of that or could have had myocardial injury on top of that, not necessarily due to ischemia epicardially, but due to ischemia due to increased wall tension and the RH ratio, et cetera. I would ask one question that perhaps I missed, but this gentleman did present hypothermic.
Yeah,
he did present with an
94.4%.
elevated white count.
Yes.
You mentioned sepsis, and certainly that clinical presentation makes one think of sepsis. I presume that there was no evidence of any infectious etiology that would have contributed to that in that.
No, a widespread search over his 39 days in the hospital never grew out a
Yeah.
single organism or found a single definitive source for infection in him. And to your other point, the amount of myocardial injury he had, I didn't put it on there, but his initial troponins, when he showed up, were 0.2. So fairly low level, but you're right, evidence of myocardial injury, but not dramatic myocardial injury like a really fulminant myocarditis or something that was really
Yeah.
flaming.
I don't know what his course of in terms of what his wedge did or end diastolic pressures were, but again, that thin wall dilated ventricle is clearly going to have increased wall stress, increased myocardial demands that may have been difficult to supply and certainly probably contributed to the spiral.
What do you think of, we've heard Dr. Mann discuss remission and then recurrent disease being very difficult to treat and sort of like recurrent cancers can be. Was this a patient that was destined not to respond to therapy?
Oof, boy, destined. That's a challenging word. I think that the consensus was, given the dilated ventricle and the thin wall, that we were probably seeing this towards the final stages of the game.
Right.
It would have been interesting to understand better what had happened, even back in December when his symptoms kind of more started. And I suspect that this had actually been going on for a much longer period of time, but due to his schizophrenia and lack of health care, simply presented really, really, really late in the course. And probably for that reason, you're right, I'm not sure that we could put Humpty Dumpty back together again after all of
So
that.
a few comments, if I may. So I think given the dilated phenotype, one can think, well, is this de novo, acute on chronic, or just acute? I too would have thought of a viral exacerbation or infection. But when we see these normal blood pressures, you're really obligated to report the systemic vascular resistance. If you have a dilated heart and your systemic vascular resistance is very high, and your output's low, you can get more forward flow by venovasodilation. And so you could do conventional tailored therapy in some patients, and that gives you an opportunity to then use medical therapy in a patient that's a responder to alter their trajectory. Because what's going to alter this guy if he didn't have an infection, insult, or something new? It was just really progressive disease, undiagnosed. But it sounds like he probably wouldn't have tolerated that. You put him on milrinone, and he became more vasodilated. In fact, was using norepinephrine. So that's a very challenging patient population, because they're not going to be able to tolerate even some medical therapy, like an ACE inhibitor, or we use some digoxin, and maybe add on a little bit of beta blockers. We've had many patients just like this where you need extended support, and then you, for some time, and then the vasodilation washes away, and then you maybe have a fighting chance. But he was doomed to not do well from the story you painted. You put a nice question whether you would pursue biopsy, and you didn't give a history of ventricular dysrhythmias, high-grade blocks. So I wasn't thinking giant cell, sarcoid, other things that may influence you in terms of management, even though there's controversies in how you'd manage that patient population, but maybe some immunosuppression. So I think you were stuck with a tough patient based on that presentation.
Yeah, the comment about the vasodilator stuff at the beginning is good, and we were able to use a short period of milrinone, but it was interesting to me how quickly then it became real overt shock, and we had to back away from that drug. It would have been nice to have a different trajectory after that. I was a little bit optimistic for the first day that maybe we could get away with vasodilators, but he didn't behave that way.
Just a minor technical note. You mentioned that you put in antegrade limb perfusion for the impella in a diseased leg. You took that off the contralateral limb and just did a male-to-male connector, or?
In this particular case, it was from the side arm of the impella sheath that we left in, so it was from that larger side port then directly to the antegrade 7 French stick in the leg, and he was a larger gentleman, and to be honest with you, maybe we could have even just removed the sheath and done the peel away. Our concern in him was, given his degree of coagulopathy, his INR was about 4 when he came in, and he had 70 platelets to his name, is that we were really wanting to minimize that kind of manipulation.
At the antegrade limb, do you use those frequently when you know it's not a short dwell time for the impella?
One of the options, absolutely, and in him, I think you're right, everyone realized at the beginning that this just wasn't going to be in a quick overnight impella and take out the next day, and so for that reason wanted to plan for the future.
And it was likely you were going to need to dose escalate in terms of inotropes and pressors, and right?
Yeah, and the coagulopathy too, I think, was a big challenge there. That whatever we did, it took many days for his INR to come down and for his platelets to stabilize, even with a lot of transfusions for his DIC.
Well, what I saw was comprehensive, thoughtful, and meticulous care with good decision making, and not always translating to a good outcome. I don't think there was anything.
I have
any
a question.
gaps.
Nils, I missed the first part. This patient presented with shortness of breath. Is that what you just said?
Strangely enough, if you read the very first statement in the ER, he says, "My blood sugars are high and my legs hurt." I think from his anasarca in his legs, that was what.
So that was his
That was his chief complaint. Yes. Yeah. Dyspnea
No, that's
was
what
really
got
not part
all
of
of
it
us
all.
off, because
Yeah.
if you presented with shortness of breath, then the algorithm in the ER comes in a shortness of breath. If your BNP is above 1,000, it's a pretty good
Right.
marker that it's a cardiac in origin, this shortness of breath, and then it goes to that track. But bridge to decision, like Maria said, it's these days we're going to face this bridge to decisions, because most of these guys show up, you don't know their social histories, you don't know where they're from. In Texas, we have a lot of people not even documented.
Yeah.
And that becomes a very difficult proposition. And this population is growing because they don't get health care till the last. And
Last
then they come
moments.
in extremists, and then you have to do all these things and take care of it. But this is the classic cold and wet, as you presented. This is the cold and wet who don't do well. The mortality is so high, no matter what you do to them. But low cardiac output with wedge of 26, impossible to treat.
Yeah. All right. Thank you.